Welcome, everybody. I'm Cheryl Ermiter, the Executive Director of the Institute of Medicine and facilitator for today's gathering. During this unprecedented time, we are thankful for you making the time to be with us today. We will make sure we use our time respectfully for you and to ensure that we get to our end goal, which is your support and your enthusiasm to understand how we can collaborate and to make systemic change. It's unfortunate that we cannot be in person. I miss seeing you all, and one day we will have that opportunity. So many have been able to get to this point with how we are working together through this IT and the Zoom process. We particularly want to thank Jan Odiaga and Torrance for setting up the IT and support. Thank you, Deborah Hodges and Bill Philstead, for your energy and eagerness to make sure we're organized and we gather all the information needed to get to today. Finally, thank you to my colleagues, Mark, Liz, and Bill, for your hard work, your thinking and vetting of how this project has been able to start and to get to this point. While many are using Zoom technologies, others may be need a refresher, like myself sometimes, with regard to where we can chat and communicate. So as you can see, you can always put in a comment in the chat function as we go through our speakers and our presentation. But let's go through what we're going to be doing today. And that is, initially, I want to welcome you, and then we will have opening remarks. We will tell you where we're at and how we got to this point. And then we're going to give you a great example of what systemic change can look like. After that, we will break into two groups: the thought leaders room, which are those who have been invited, who are in coalitions and alliances, and those who really understand and know the data that is being gathered currently, especially during this time of COVID. The second room is the guest room. That guest room is for our invited guests. We'd like to have an opportunity for you to network and to share your thoughts about the information that has been shared. During that time, we are really eager to think about how we can make a collective social impact for our region. Then we will reconvene to hear a summary of our guests at 11 o'clock and then highlight how to bring these actions forward. For now, I'd like to introduce the president of the Institute of Medicine, who has had the vision and the relationships to take the work that we've been doing forward for an incredible regional collaboration. Cheryl Whitaker, welcome and take it over.
Thank you, Cheryl Ermiter, and good morning, everyone. I'm going to let Professor Carlson upload the slides here. We'll get started. I want to thank everyone for kind of hopping on today. We've all hopefully become expert at the Zoom meetings, and so far so good. I'm pleased to serve as the Chair of the Board of Governors and President of IOMC, elected in June duly by the fellows, and I appreciate your vote of confidence in me. Next slide. The Institute of Medicine has a long history of catalyzing when the organization or the, can I go back, please? Sorry, when society needed action. And the organization was founded in 1915 by 15 physicians wanting to improve the quality of care here in Chicago. We were first to convene everyone around the need for kind of a streamlined procedural-based kind of autopsy process. We advocated for broader access to emergency public ambulance services back in 1945. And in 1954, when society needed a push, we worked to ensure that hospitals would bring Black physicians on staff so that those doctors were able to practice and serve their communities more fully. We've had a history of doing this type of work. This work we're engaged in today finds us at the kind of, in the midst of a societal crisis, and is now no more important than it's ever been. Other sort of places, the Chicago Patient Safety Forum, we helped to launch, and that organization since spun off and became its own organization. So we've got a history of acting when action's needed, and we look forward to hopefully doing more of that over this coming year. Next slide, please. So State of Health of Chicago in 2017, many of you attended that convening, catalyzed ways for members to look to engage more significantly. It actually laid the groundwork for a strategic plan that included research into the development of a trust concept. The Portis Foundation and the Michael Reese Trust granted us an award in 2019 to begin to explore, identify themes and viable approaches. Next slide, Professor. So with that, I'm going to introduce retired Professor of Nursing Elizabeth Carlson, who served as the chair of the Management and Implementation Committee responsible for this work. And as I turn this over to Liz and the rest of the group here to take you through the morning, I want to announce that October will be an important month for the Institute of Medicine and for all of our fellows and those who want to collaborate with us. We'll be releasing next week a calendar of programming for October, which will culminate in a report out of this work, along with addressing the status of Chicago and the greater Chicagoland area in Illinois with COVID-19. We're going to be focused throughout the month, actually, on several topics that include the influence of wealth disparities on health disparities. We'll have a topic on COVID-19 and the importance of integrated care. And then on October 23rd, that's going to be the grand State of the Health of Chicago convening for 2020. We're not able to convene in person, but we anticipate a robust virtual convening with all of you there. So we look forward to announcing that and having you all sign up to attend and participate in these various meetings. So we look forward to today and to the future of the Institute of Medicine and working with all of you. Thank you. Professor Carson.
Thank you very much, Cheryl. IOMC has and continues to have a long history of interest in and commitment to health disparities and inequities that exist in Chicagoland. The Portis and Michael Reese Foundations have demonstrated a similar interest, and we are grateful to them for providing IOMC with a grant to support our efforts to investigate ways forward through a Management and Implementation Committee, or MIC. I would also like to recognize and thank my co-chairs and the members of the MIC subcommittees who did the work you will see reviewed today. They are named in the materials you received. Oh. Sorry. Okay, sorry. Oh, there it is, sorry. Well, maybe not, hold on. So. As most of you know, interest in addressing social determinants of health has accelerated rapidly in recent years. These structural barriers to disadvantaged communities has led to the insightful and to the point aphorism, zip code matters more than genetic code. At the same time, there is recognition that no single stakeholder can provide the perspectives, skills, and sustained funding necessary to address inequities. Realizing this need to work collaboratively, IOMC approached these issues from a perspective not used in Chicago previously. Out of this grew our work on the possibility and potential of a well-being trust. Due to IOMC's recognized role as a neutral broker or convener, We believed we were ideally suited to serve as a catalyst for this work. Beginning about 2 years ago, we examined the ways that social determinants of health are addressed in various communities. To this end, we reviewed what others have proposed and implemented nationwide to address these issues in a collaborative and organized manner. We knew there were and are both overlapping and gaps within and between efforts. The goal was to examine opportunities to improve current efforts that would, if implemented, make a difference in the well-being of individuals, families, and communities. In 2017, the IOMC State of Health of Chicago, or SOHOC, focused on how social determinants of health are addressed in various communities. We reviewed what others are doing nationally and locally to address these issues in a collaborative manner with the goal of determining opportunities to improve current efforts. We invited Dr. Soma Stout, a national expert and executive lead, 100 Million Healthier Lives, to gain a better understanding of best collaborative practices, innovations and approaches, and the importance and value of listening to communities active in addressing these issues. In July 2018, the IOMC board supported the development of a Metro Chicago Community Wellbeing Trust facilitated by IOMC. To further our common knowledge of well-being trusts, IOMC invited John Auerbach, who headed the Massachusetts Wellbeing Fund, to present the annual meeting. Subsequently, IOMC reaffirmed and announced its plans and commitment to this work. In October 2019, we received a one-year grant from the Portis Michael Reese Foundations to conceptualize and catalyze the formation of a well-being trust, develop the governance of the trust, formalize the founding trust membership, and develop the plan and budget for the implementation of the trust. We established the MIC and 4 subcommittees to gather information. We were purposeful in ensuring a broad and comprehensive membership of recognized leaders to inform our work, sought out other national and regional experts, and engaged the help of local university students in this work as interns. While work is ongoing, we have developed a compendium of rich resources and reports. These can be shared and will be used towards developing future steps. Suffice it to say, we have tried to be as diligent and thoughtful as possible. Each subcommittee used this detailed qualitative approach to guide its work. The National Trust Subcommittee reviewed several of the growing number of well-being trusts across the nation. This included a particularly detailed analysis of 4 widely regarded trusts: Michigan Health Improvement Alliance, Wellbeing Trust California, Massachusetts Prevention and Wellness Trust, and the Colorado Trust and Colorado Trust Healthy Communities Initiative. Reviews also considered their applicability to Chicagoland. Recently, we interviewed a leader of the Milwaukee Healthcare Partnership and Milwaukee Anchor Collaborative and learned there are definite lessons to apply to Chicago. One interesting observation is that most trusts are at the state and regional level, with few at the metropolitan level, which would make the trust focused on the metropolitan Chicagoland different and unique from other well-being trusts. Obviously, funding is needed for a Chicagoland trust, and how that will be structured and what the sources of funding will be is yet to be determined. While there are significant variations among well-being trusts and alliances, the most promising ones share these key characteristics, which are therefore likely to be important success factors. I am sure they will be further touched upon by our guest speaker today. To date, the local coalition subcommittee has been able to identify over 40 coalitions or alliances in metropolitan Chicago addressing aspects of social determinants of health, equity, and drivers of well-being. We know we don't have a complete list currently, so should you know of coalitions or alliances, we would appreciate your sharing their names with us. Our key observations to date are: there is a significant variation in size and scope of activities of local coalitions and community groups. Some are single issue focused, while others are complex, multidimensional interventions and organizational partnerships. We are led to conclude through a review of publicly accessible websites and an online survey of coalitions that we conducted that several organizations have overlapping focus areas while gaps in coverage of need persist. There is a lack of or few broad multi-sector collaborations, and many organizations struggle for sustained funding of programs over time. We believe that since resources are tight and likely to remain so for some time, the ability to demonstrate outcomes achieved with the resources used has and will become even more important, if not critical. Let me say that again. We believe that since resources are tight and likely to remain so for some time, the ability to demonstrate outcomes achieved with the resources used has and will become even more important, if not critical. Hence, the analytics and metrics subcommittee is looking at data and measures relevant to social determinants of health from public and private sources, both locally and nationally. The goal is to develop a framework for potential shared short, intermediate, and long-term outcome measures and indices that combines existing publicly available measures with novel approaches for real-time monitoring and that are relevant to local coalitions. The intent of this effort is to align with outcomes that coalitions are trying to achieve and help identify what is working within and across organizations. It would support important qualitative assessments. Lastly, the effort of this subcommittee is to develop a glossary to assure we all have the same understanding of commonly used terms and that we use a common language. As stated earlier, the goal of the MIC subcommittees and focus groups is to determine the level of interest in participating in the creation of a well-being trust or initiative for Chicagoland. The work includes developing the governance of the trust, formalizing the founding trust membership, and developing the plan and budget for the implementation of the trust. Today, we begin our next steps with this focus group. Thank you for joining us. We will have a second focus group on September 25. These data from both groups will be analyzed and synthesized and presented at SOHOC, or State of Health of Chicago, on October 23. Subsequently, we will disseminate the findings broadly. We invite you to attend SOHOC and join in this exciting undertaking. Thank you. Now I have the privilege of introducing our speaker. Dr. Madhura Mansabdar is an internal medicine physician. She currently serves as the Chief Clinical Integration Medical Officer of Mid-Michigan Health. Additionally, she is the Medical Director of Mid-Michigan Health Network, Mid-Michigan Collaborative Care Organization, and Connect Care. Her current roles span leading population health initiatives, working with physician practices towards MCHC designation and value-based care, quality improvement, ACO development, provider credentialing, building collaborative payer-provider relationships, and utilization management of the self-insured plan Connect Care. Prior to this, Dr. Mansabar practiced as an internal medicine and diabetes physician with Mid-Michigan Health for 14 years in Alma and Mount Pleasant. Dr. Mansabar lives in Midland with her husband and 2 children. Welcome, Dr. Mansabar.
Thank you, Elizabeth. Can you hear me? Very good. Thank you for the gracious introduction. As I share our story, I will plan to review why we came together, what we focused on, and how we are achieving collective impact in our 14-county Central and East Michigan region. I will end with some pearls for success that we learned through our experience. It is said that a picture says more than 1,000 words, so I'd like to start with a brief video.
When it comes to making change on a large-scale social issue like health and healthcare systems, nonprofits often follow the isolated impact model. Isolated impact occurs when a single organization, or maybe lots of single organizations, are working at finding a solution to an issue. With all great intentions, each group tries to use their pull to create positive change. But the only way to actually realize this change is to pull together in a collective impact model. It takes all of our stakeholders being convened, pulling together towards a common goal to actually elevate the system we're trying to change. This is Mahaya. All of Mahaya's efforts in the area of health are centered on improving the quadruple aim, which includes population health, quality of care and patient experience, cost of care, and improved well-being of healthcare providers. Mahaya's presence in the Central Michigan region is the collective impact model in action. With everyone pulling together, we can and will achieve a thriving community of health excellence for us all. Visit mihia.org.
Great. So pardon the glitch initially, but I hope you got the picture. So with the history of Mahaya, we started as a concept in 2007, a concept of a regional entity to promote health-related collaboration in Central Michigan University's research center. This started initially as a planning grant from the Michigan Department of Community Health, which actually, it started as with the concept of building a regional health information exchange. That didn't actually pan out due to budget deficits, but we did start in 2008 as a chartered value exchange by the US Department of Health and Human Services to build a healthcare system where consumers, providers, and payers make decisions based on value and quality. In 2010, Mahaya was selected by the Institute for Healthcare Improvement as the first region for advancing the triple aim in geographic regions. In 2011, the Articles of Incorporation were approved by the state of Michigan, and we had our first board meeting. The vision of Mahaya then is to become the healthiest, thriving community with the best quality and value in healthcare. This is indeed an aspirational vision. Our mission is to improve the health of people within our region through effective use of information and collaboration to establish our region as a community of health excellence through a comprehensive focus on population health, patient experience, cost of care, and provider well-being. So why are we really doing all of this? Clearly, we all agree that the current system of cost trends in healthcare, as well as the outcomes that we're achieving with healthcare, are not sustainable. The choices that we make have an enormous impact on healthcare outcomes. National goals and community and common standards are good, but real improvement really takes place in a local setting where stakeholders know and work with each other. We work on a regional level. Common values are more likely to emerge in this situation. Solutions depend on context, and knowledge of context is more accurate locally. So the assets that Mahaya brings to the table are: we are a multi-stakeholder organization across a 14-county region. This includes large employers, most notably the Dow Chemical Company and other major employers, 4 health systems, federally qualified healthcare centers, a medical school, multiple local residency training programs, universities with health professional training programs, public health departments, and community-based organizations. We have a unifying vision and mission. Our board has both power and influence. We have national recognition and positioning, initially as a chartered value exchange, and then as the platform through which the IHI Triple Aim was launched in our region. Our size and scale lends to being large enough to matter, but small enough to be effective. With this effective size, data analytics are more possible. And it provides an appealing size for federal and large private funding or focus groups, such as the IHI's initiatives, as well as the Chartered Value Exchange. Mahaya's funding model is transparent, as you can see in this slide. It includes contributions from corporate stakeholders, community foundations, community members, grants, and affiliate organizations. The organizations that support are offered the option to provide global funding for Mahaya, or for specific initiatives that they have a greater interest in supporting. Mahaya's board consists of leaders with influence and decision-making capacity, and it comes from the organizations that support Mahaya. These organizations and these leaders are significant movers and shakers in the region. Committee members are selected based on their interest and passion and their roles in various organizations in the region. The committees are also staffed by Mahaya employees and consultants selected based on specific initiatives. The board consists of CEOs of CEOs of health systems, deans of local universities and medical schools, leaders of the public health departments in our region, insurance companies, and major employers. Some of the expected benefits that an organization like Mahaya brings to our region is to advance the reputation of our region as a place with demonstrated commitment to a community of health excellence, as well as a leadership status at the national level. It gives our region a voice in state as well as national actions, and we are able to secure both external expertise, resources, and leverage to advance our objectives. It creates a platform for building relationships and trust in our community. It enhances the ability of health systems and providers to meet tough challenges for improved quality and cost containment. As you know, this is an area of significant challenge for health systems today, to be able to manage the cost trend and continue to improve healthcare outcomes. Mahaya, an organization like Mahaya, facilitates focused community and regional priorities through collaboration with payers and providers to create a win-win scenario, such as the implementation of the Triple Aim in our region, as well as the patient-centered medical home several years ago. It retains and attracts new business, and it helps attract more research dollars and grant support for healthcare research in our region. Many of you may already be familiar with the Institute of Health Improvements, AAAIM, which Mahaya was the first region to be able to implement this on a geographic level. The core fundamental framework that drives Mahaya's work is the AAAIM. This includes, as you see in the diagram, population health, experience of care, and per capita costs. At the individual level, this translates to good or better health, good experience, and good value. Mahaya has adopted the AAAIM framework and uses a data-driven decision-making approach to establish metrics related to each of these different priorities. So for example, under population health, our goal is by 2024, all counties in the Mahaya region will rank within the top 2 quartiles for health behaviors using the community health rankings source. Now, if you actually look at our data, there are several counties in our region. This is fairly rural, and there is a significant amount of poverty in the region. And so there are several of our counties that actually are in the lowest quartile. And so this is an aspirational goal. Quality of care and patient experience. Within that, our goal is for health systems in the Mahaya region to strive to obtain the highest possible hospital safety grade. In this case, the source used was VPROT. And then the final area of top priorities are cost of care. So our goal for this was to keep the cost of care inflation trend for the Mahaya region within the consumer price index trends. So a sample of the current initiatives within these macro goals are listed in the particular slide that I have in front of you. I am going to try and take that back. Are you able to take the slide back to slide 10, please? Thank you. Thank you. So to list some of this is a sampling of our current initiatives. And the first, again, remember that we started as actually a health information data source. And one of our major initiatives has been to create a health dashboard to reflect healthcare outcomes in our community. So some of the factors here are to monitor community health status as it relates to quality of life for the region and its economic development and well-being. So this health dashboard displays nationally recognized and other health measures used to describe and monitor the population's health, as well as to serve as an educational tool. This particular dashboard has continued to be improved over time and is used for a variety of different reasons by many different entities within our region, including developing the community health needs assessment on a regional level, as well as to potentially apply for grants related to various research projects or quality improvement projects in the region. The other initiative is the Digit Community Gardens, which is a recurring annual project that creates community enrichment and provides opportunities for physical activity, social interaction, therapy, and access to fresh vegetables for residents of the Mahaya region. Healthier and Happier Families through Corbo is an initiative that helps to improve long-term health outcomes and reduces the impact of obesity and diabetes in children, as well as their families, through the virtual program featuring the Traffic Light Diet, which was created in Stanford. Centering Pregnancy, one of our very successful initiatives currently, provides group care to pregnant women in an effort to improve the outcomes for both infants and mothers in our region. The Region 5 Perinatal Care System Quality Improvement Initiative focuses on convening multiple stakeholders to establish goals and strategies to improve maternal and infant health in Prosperity Region 5. The primary role is that the team will identify evidence-based practices, support data collection, conduct a regional assessment, host a few different learning summits and enhance awareness, as well as participate in statewide networks to develop a multifaceted quality improvement plan. The Diabetes Prevention Program, one that many folks are familiar with, is focused on preventing type 2 diabetes through a 10 to 12-month lifestyle change program, and it focuses on strategies to incorporate physical activity into daily life and eating healthy. It is supported by healthcare benefits, workplace wellness offerings, Medicare starting in 2018, and initial funding was obtained through a community foundation. The last of the initiatives mentioned here, again, these are just some of the initiatives, is the regional opioid strategy. Can we advance that slide, please? Thank you. Is the regional opioid strategy, which is a comprehensive strategy designed to build a coordinated approach to respond to the opioid crisis. Most of us have heard of or know someone impacted with opioid addiction. So you can well imagine how incredibly important something like this was. Yet each individual group or health system may find this too daunting of a task to be able to achieve on their own. And hence Mahaya stepped in to develop this comprehensive strategy. This was a strategy map that you see on the slide in front of you. A map of services, interventions, initiatives, and actions from multiple sectors and regional community partners and coalitions, producing a complete catalog of current activities and approaches across the region. So folks can actually click on this particular map and define various initiatives that are occurring within the region. This serves as best practices that folks can adopt across the region or learn about and get additional support. I will now shift gears to describe an initiative called Thrive. Thrive stands for Transforming Health Regionally in a Vibrant Economy. Thrive has been developed with support from two foundational organizations, Mahaya, as well as the Great Lakes Bay region. Mahaya collaborated with the Great Lakes Bay region to build a shared path to a positive future in our region. As you can see on the slide in front of you, these two backbone organizations worked together to develop both the steering team for Mahaya as well as develop its multiple initiatives. This initiative actually started through an extensive planning and preparatory process started in 2017. This included initial phases of a detailed analysis, systems mapping, and modeling to be able to achieve a broad understanding of the entire health ecosystem and the interdependence of health and economic success in our region. It led to the formation of a master portfolio of interventions, which we can go through briefly on the next slide. So what you see here in front of you is a complex slide, but to briefly explain this, the 5 priorities of building provider capacity, preventive care, investing in social determinants of health, building an attractiveness engine for the region, and job creation were where we landed as our priorities to help improve overall health and economic success and outcomes. In the Thrive portfolio, in these 5 broad categories, within them there are 35 different interventions that have been identified and will be implemented in a phased manner to be able to achieve those broad health and economic outcomes that are listed. A variety of funding options have been considered, and we have landed on the Health and Wellbeing Fund as the first option, which will be built out over 3 generations of funding. As I mentioned, these interventions will be planned and implemented in a phased manner. So we had the phase 1 kickoff in 2018, and this includes, again, those 5 broad priorities. So very briefly to mention, Within the regional attractiveness engine, we've been able to build some meaningful relationships with influencers of economic outcome in the region, including all the way to Metro Detroit. We've been able to identify 50 plus new prospects for the region. Great Lakes Bay region did come to a finalist position on a European cheese production facility. We submitted multiple RFPs for projects for the region and coordinated a massive tour with leaders of various companies across the state and the region. Looking at some of our developing mental health and provider capacity, again, to meet the needs of providing care for behavioral and mental health is a matter of tremendous priority, not just for our region, but really across the nation. Through this process and through Thrive, we were able to start a psychiatry residency program, a psychiatric nurse practitioner program, and a psychiatric child adolescent fellowship program. We were able to bring in 12 new psychiatrists to our area under Central Michigan University's program. When we look at prenatal, maternal, and infant health through the centering pregnancy model, for example, we had 500 births, 500 plus births happen through that centering pregnancy model. And our outcomes are as follows. We had 36% reduction in spontaneous preterm births, 44% reduction in the risk of low birth weight babies, and a 28% reduction in the risk of neonatal ICU stay, as well as a 15% increase in breastfeeding rates. So again, for those of us who are engaged more deeply in prenatal, maternal, and infant health, you can imagine how significant these outcomes are. In regard to patient safety, all regional health systems have committed to a zero harm target with public accountability and collaboration. With regard to adverse childhood experiences, again, we know that childhood trauma has profound and lifelong impact on health. Through Thrive, we were able to enhance awareness related to trauma-informed care, and were able to conduct educational programs through schools, universities, and other professionals to be able to make them more aware and screen for adverse childhood experiences as a source of adverse health outcomes. Moving into phase 2 interventions, these have been identified now and are within the broad categories of addressing educational challenges, preparing youth for STEM careers, looking at the access and quality of food, adopting various strategic actions to address financial stability in the region, and then to strengthen primary care and coordination models. Just in the interest of time, I won't go into more detail on each of these programs, but would be happy to take questions. I will now move to the final part of my presentation and share how we have managed to accomplish so much and consider a few pitfalls to avoid. Building and sustaining a broad coalition is a challenging task indeed. So some of the pearls of success that we can share are, it is very, very important to be able to develop and nurture a vision of culture, a vision and culture of collective impact through collaborative effort. A critical component of this is to secure the commitment of an influential leader with a vision, connectivity with national leaders and resources, as well as the leverage and grit to be able to sustain this effort through difficult times that we will inevitably encounter. In our region, we have had the great fortune of having an influential leader like this, and her name is Dr. Kathy Balzi. She has been the Chief Health Officer for the Dow Chemical Company, which is one of our major employers in the region. It is very important to carefully select the board in order to have an effective and sustainable governance organization. The board should convene leaders from supporting organizations that have knowledge, shared sense of purpose, and a collaborative mindset. These leaders should also be the ones with decision-making authority or influence. We should strive to demonstrate tangible benefits for our participating organizations. This needs to be an ongoing process. This benefit could come in the form of recognition, visibility, as well as outcomes for those individual organizations. And this is critical to ensure ongoing support from these organizations. It is important to set up a reliable and funding model. It can so happen that the same sources get recurrently tapped on for both financial as well as human resource support. It is very important to spread that work and cost effort across a broader community of supporting organizations. It is important to maintain shared objectives through ongoing dialogue and a well-developed process of strategic planning. Having communication skills as well as tools in the form also of toolkits that different community leaders can use to be able to share and communicate the vision as well as the different initiatives that are being undertaken in order to maintain that culture of collective impact. It is of critical importance to be able to seek and listen to feedback from your stakeholders. The process of having organizational support from organizations across the region is an ongoing process. And hearing the feedback that you receive from these organizations is important to maintaining that ongoing support. We need relentless focus to achieve the strategic mission and goals. And even as we do that, we have to avoid getting detracted by the next funding opportunity and remain true to our mission and goals. And then finally, we need to focus on a few carefully selected initiatives and take them all the way to completion, knowing that, of course, this work is never complete. Nevertheless, the importance of focus and not getting too broad and having our staff or supporting organizations get overwhelmed is important. In summary, building regional multi-sector collaborations is a challenging task that is well worth the effort to achieve collective impact. Thank you for the opportunity to share our story. I hope it will help you in your journey towards collective